Hi, everybody. I know I've been gone for a minute, so I'm just waiting for people to pop on. So this is a special edition of Facebook Live. Make sure I want to see if I can see it on my other computer. Okay. Perfect. Okay. Okay. People are jumping in. Good morning. Good morning. This is great. Perfect. So this is our Facebook Live special edition, and we are here with Dr. Alex Lacasse, and he is an infectious doctor at St. Mary's Hospital. And we're just going to have a conversation about COVID-19 with everything that's opening up in the next week. We just want to have a conversation about how safe we should be going forward. Thank you for coming, Dr. Lacasse.
Well, thank you for having me. Pleasure.
So whenever you're ready, we're ready.
So just for recent history perspective, St. Mary's, hospital in Richmond Heights, we've been unfortunately, very busy with COVID. And I should say now the COVID season, I guess, since mid-March, really, we were part of the hospitals that had a significant surge of patients. So we saw quite a number of patients from the community, predominantly African American, that were coming to our hospitals with diverse symptoms. And, obviously at the beginning, we're writing history as we go. So we've learned much more about the disease in the last couple of months now, being an active part of this endeavor to make sure that our patients are treated appropriately. So we actually had a multidisciplinary approach at St. Mary's, where we have our incident command with significant leadership, myself included, from the infectious disease part in infection prevention. But this is a team effort, and this is not a one-man show type of strategy. And we were a very strong command center with different bodies involved with, tasks to do different things, and meshing really well together, not only from a physician standpoint, but nursing leadership and support staff. There's a lot to coordinate in a surge. So proud to say that I've been a part of that team, since the beginning, and really try to make our patients the safest possible, and make sure that, our families, even if they physically cannot come to St. Mary's, to actually still be in contact with their loved ones and make sure that they're part of the process. So, for example, palliative medicine was also readily involved. We had all of our administrative leadership present at all venues of this task force. So, we've dealt with a lot of growing pains, if you will, starting with a lot of acute respiratory failure, where a lot of pneumonias and a lot of patients ended up on the breathing machine. So, and we've learned from it that we decided to actually try another way to approach and giving oxygen, but not necessarily through a tube in your throat, but really with a really big face mask, and making sure that you get what we call high flow oxygen. Because we've learned early on that when you end up in the intensive care unit on the breathing machine, this is not a good thing at all. And in fact, we had about half of our patients that ended up in that predicament actually pass away. So we decided to change our strategy. And we were lucky enough at St. Mary's to have a facility where we could have different areas of the hospital able to have these patients, that we also keep our nursing and physician staff as safe as possible with different, what we call PPE, right? Protective personal equipment. So we had to coordinate all that. We saw obviously an influx as I mentioned, in mid-March, end of March. That was very sustained for about a month or so. And then we saw a steadily decline starting at the beginning of May. And I'm happy to report that, at least for the last 7 to 10 days, the decline has been dramatic and has been to numbers that we've never been so low before. Not only just present in the hospital, but patients that come into the hospital when we think they may have COVID turn out to have other things than COVID. So that's really reassuring. That means in the community, I think people do whatever they can to protect themselves and making sure that the transmission is at the lowest possible. Are we still waiting for a second surge? It's still a possibility, especially with the community having reopening of different activities, especially involving, the community and children and whatnot. So, obviously, we still have to use our best judgment to make sure that transmission does not get high again. Now, I mentioned that it was very prevalent or we saw a lot of numbers from the community in the beginning, and towards the mid-April, end of April, we saw a shift really of patients, not necessarily from the community, but from the nursing homes and the other types of long-term facilities where we know that these fragile individuals were really affected around that time. So we saw a shift there of patients that really were coming from these places. We are still working on making sure that we keep our employees safe as much as possible. And, we still have appropriate protective equipment. And that's just something that's really important for us in our incident command, is that we make sure that, our employees are protected. So throughout this, we've learned quite a few things, and we were actively involved in seeking out treatment options. So we were part of the national research investigation undergone by Mayo Clinic, and we're under that umbrella from a plasma treatment that has been started here at St. Mary's and other SSM in St. Louis. And we also part of the distribution hospitals that receive remdesivir, this new treatment that has been also released by the FDA. So we have a lot of different options. We also been in communication with other hospital systems where they use different strategies, especially with the immunosuppressive treatment. So, for example, steroids. So, being a program director of an internal medicine residency program here at St. Mary's, it gives me the opportunity to really reach out to different other places where there's other studies and other things that people look at, so that we can bring that back here and make sure that we offer that to our patients. So this has been ongoing for really since the mid-March. And I think, looking back at what we did, I think we tried really our best in this very difficult times, and we've had our ups and downs. But I think I sure think that Richmond Heights should be very proud of our hospital. I certainly am proud of the team that we were on, that I was part of, and I think it goes to show that we were there for the SSM mission, and I think that's a good thing to see. I think I'm always been a half full glass kind of person. So you can look at these things that are really happening to us, and you can be positive about it, or you can be negative about it. And I think it brought out a lot of good in a lot of people, and these are really the people that I want to work with every day. So, and same for families. I'll be honest, with discussions with palliative care and other physicians, families have been probably our number one supporter. The community has been outstanding when it comes to what they call heroes. We don't view ourselves as heroes. We view ourselves as making sure that we're in this for for the good of the patient, really. So, and this is the calling that we had, and it was a good thing to put that into a real practice, in certain ways. Do I want that to continue for a long time? No. Obviously we want to make sure that we go back to normalish type of activities. So again, the reopening of the community is something that is inevitable. We have to go through it. We have to go through it in a very methodical and as intelligent way as we can, based on what we know. So it's the same discussions that always comes up, and it's always wash your hands, don't cough in others people areas, and personal space, and again, maintain some social distancing. And these may actually be very difficult to do in some situations. And again, we cannot just stay cooped up in our house or in our residence all the time, but certainly we just have to be not swinging the pendulum the other way and completely release everything and have gatherings that are out of control.
Understandable. Totally understandable.
Yeah.
So, Dr. Lacasse, so we have a few questions that
Sure.
that people posted. So what's the latest update on your COVID-19 patients at St. Mary's?
So we actually, when we were in the height of the surge, St. Mary's had about 65 patients that were just for COVID. So it was, on different floors and that were designed that way. And to give you perspective, right now we have about 15. So, so a dramatic change. That's a number that counts the one that have been diagnosed for since their admissions, and the ones that are coming in that we have to make sure if they have COVID or not. Typically on a day we had about, in the height of the surge, we had about, at least 15 to 20 new patients that we had to make sure if they had COVID or not. Now we have about, 3 to 5 on every day. So much decrease.
Yeah. So I know that when all of this started, they were like, quarantine yourself for 2 weeks if you were exhibiting some kind of symptoms. So when people come into the hospital, can COVID last longer than those 14 days?
That's a very good question. You guys are really prepared for this. No, it's an outstanding question. The reason it's an outstanding question is that the answer has evolved over time because of the data that we have either from China or other countries or our own country at other places where they experienced a surge early on. So, and I can tell you that before probably the last 2 weeks or so, I would have not had a great answer for you because we didn't know. Yeah. So the latest research will tell us that the test that we use is a test where we swab the inside of your nose, really far behind. And it's a test where it detects part of the virus that we call RNA. So humans are made of DNA. This virus is made of what we call RNA. It's a little different. Okay. And we measure that. So it's not directly measuring if the virus is there, but it's the important component of the virus. The problem with that is we don't necessarily detect viruses that are at full strength and able to infect. So because doing this needs a special equipment in the lab, not to infect lab workers and whatnot, that we don't necessarily have in the St. Louis area. So, but there's been a study most recently in Canada, actually, where they looked at if there was viable virus until X number of days. And that number of days was 8. So after onset of symptoms, it seems that the possibility to transmit to somebody else or that you're infectious is 8 days. There was a previous study in Germany early on that was also 9 days. That was the quoted number.
Okay, perfect. So,
Unfortunately, the test that looks for the RNA, unfortunately, the test that looks for the RNA is actually can remain positive for a long, long time. And people were very nervous about that at the beginning because a positive test unfortunately, does not mean you're still infectious. It's just remnants of the virus that's still
mm,
lurking there, but not necessarily causing problems.
have you all seen anyone come back that's had COVID before and they've come back and had it again?
Wow. You guys have very good questions. Okay. No, we have not seen. And that's also very intriguing that you actually asked me. This is very apropos because I could have said, if it would have been a week ago, we don't know the answer to that again, right? So
Right.
the latest research on that, where they actually looked at, patients over time, okay,
Mhm.
is really about the latest that we've looked at, or the longest is about 55 days, and patients are not necessarily reinfected. We also know from our plasma program
Mhm.
that people that donate their plasma were infected. They have the antibody. This is why we use their plasma to give to another patient. And we partnered with Mississippi Valley Blood Bank on this, and they use the University of Iowa for their test. And we've learned through the same donors week after week after week, now for the last 8 weeks, have continued to have antibodies that are protective. So that means they cannot be infected. And that's about a 2 to 3 month lag. Beyond that, we do not know.
Right, right. Because that was another question. The antibody testing, is any COVID-19 antibody test accurate enough to be worthy of the cost and effort?
Absolutely, because for multiple reasons. Okay,
Mhm.
one, we will know exactly the number of people that have been infected.
Mhm.
Instead of just relying on the nose test, the blood test will tell us, hey, you may not have had a nose test that was positive, but hey, you have the antibody, so you were infected. That's number one. We
Okay.
can use that to also make sure that the plasma we give is actually plasma that has the antibody that can fight the virus. So we
Mhm.
absolutely need that test. And these are the two main things. The other main thing is, if you have developed the antibodies, and usually it's around the 3 to 4 week mark
Mhm.
after the infection, that means you're not for sure infectious anymore. And we don't have to continue isolation and whatnot. So that means, and that becomes important for families, for example, that have other folks in their families that have chemo treatment or
Right.
on medications that suppress the immune system, to visit their loved ones. So it has different implications. So that test is certainly worth it.
Mhm.
Is it the perfect test? No, there's no perfect test, and we've learned that somewhat. I wouldn't say the hard way, but we've relearned that through this COVID pandemic.
Yeah. So the next question is, how contagious is COVID-19 in comparison to chickenpox?
To what?
Chickenpox.
Wow. Okay. All right. I like those questions. So chickenpox, and there's an index of, and I'm not going to bore you with details, but there's an index of infectivity, if you will, for every pathogen. So every virus or bacteria.
Mhm.
And COVID is actually not that high as an infectious virus. It's a little higher than influenza, but when you deal with viruses like measles
Right.
and chickenpox, these are extremely infectious. And the reason they're extremely infectious is that COVID and flu is what we call droplets. So when you cough or when
Mhm.
you sneeze hard, there's like a plume of droplets. These droplets kind of fall down, and it's about 6 feet. Okay. They don't stay up in the air for a long time.
Right.
Chickenpox, measles, they stay in the air, and that these little viruses can travel long distances.
Mhm.
This is where a measles patient, for example, can be in one room and through the air duct system, the virus can go to the completely end of the hospital and infect somebody.
Yeah.
Do not see that with COVID.
Okay. That's great.
Mhm.
The next question is, in 1995, a movie, Outbreak, with Dustin Hoffman was an accurate portrayal of an infectious disease. Do we see that? Do you know what that movie is, Outbreak, with Dustin Hoffman?
Absolutely. They walk around with spacesuits. Yes.
Yes. Yes.
Yes.
They just-
They
Yeah.
were referring more to to a Ebola type virus.
Right.
And in fact they probably took that from what we call the Marburg virus, which was in Germany in the 50s or so. So that was actually closely related to Ebola. So
Okay.
this is totally a different one.
Yeah.
As far as contagion is for Ebola, that's extremely high, because Ebola also lives on the body and all that. And there was a lot of transmission through, the rituals of death, burials, and all that stuff, especially in Africa with that culture. So no, we do not see that COVID is as dangerous, if you will, as this. You have to understand that, we're looking at this infection. 80% of people that get COVID will actually have a cold or flu-like symptoms.
Okay.
And the ones we see, unfortunately, at the hospitals are the 20% that have a significant severe component to it, where it will attack the lungs and people will need oxygen, and it can attack different parts of the body, including the kidneys and the brain. So, we see, unfortunately, the worst cases, but people have to understand that 80%, 8 people out of 10, it will be a common cold or flu.
Okay. That's great to know.
Mm-hmm.
Another thing that I want to know, the different symptoms. So I have a friend and she's a nurse, and she had to take time off because one of her patients had COVID, but she wasn't exempt. She didn't exempt any of the normal symptoms. It was diarrhea and vomiting that this lady was experiencing. So she didn't have a fever or any of that. She didn't cough. So, is COVID is it mutating?
No. I think it's because there's different types of presentation of the same virus. We actually also saw that in the 2009 swine flu or H1N1. In fact, there was predominantly GI symptoms of the H1N1, and that's why we were mystified by it. So this is not something that is not repeating itself. So COVID, the classic symptoms would be respiratory symptoms, just like a flu-like illness, right?
Right.
Fever, malaise, you just kind of feel yucky, and a lot of congestion and sore throat and coughing. These are the things that you will class, and shortness of breath is a big one for COVID. We've learned through seeing many, many, many patients that some patients really it's extreme fatigue, extreme weakness, GI symptoms, nausea, loss of smell or taste. Okay? Some of these symptoms, like loss of smell or taste, predicts mild disease.
Okay.
When you're really short of breath, can predict worse disease. So we've seen a significant fever response with that virus, and we're talking fevers for significant amount of days. We're talking fevers for 5-7 days. We've seen that. It's a tricky virus because it does not, it's not always the same presentation on every patient, and that's why we have to be very careful at labeling. Oh yeah, this is not COVID. Oh yes, this is COVID. We've been throughout our strategy of incident command and leadership at St. Mary's, we have seen different types of presentation, and I think because we were very open-minded to make sure that we don't miss everybody, so
Mhm.
or anybody. So and I think we've learned that as well. So the loss of taste or smell is an interesting one. And
Yeah.
that was identified early on. And we've had even, nursing and physicians and physician in training. So one of my residents, for example, unfortunately got ill from COVID and
Mm.
had loss of taste or smell, but had a relatively mild disease.
Yeah. COVID is something else.
Yeah,
Uh,
and what we've seen also is blood clots with COVID. So we saw,
oh, really?
yeah, we've seen quite a higher number of clots either in the leg or in the lungs, especially
Mm.
the lungs. And that's something we look for as well. So when people are very short of breath, this is something that it's in the back of our mind. So it's unusual, and we see also clots develop later on after the infection. So it's interesting. We're learning more and more about this.
Okay. So our community center is opening up this Monday coming up. So we're supposed to do the temperature checks before everybody walks in the door.
Yep.
So the questions that we've been having are if someone is asymptomatic and they come into the building and they infect other people, but they don't know that they have it. So because they're not, experiencing any
Yeah.
symptoms, um, what's the best way that we can keep everyone safe from the asymptomatic people?
You're talking about symptoms, not signs, right? So,
Right.
because, we have a process here, for example, at the hospital that
Mhm.
we do this. We have this, we ask questions, the appropriate questions about symptoms, and we
Right.
also have a temperature check, and if you have a fever, even without symptoms, you're not going to enter the building. Okay. So, because you may be at the early stages of the infection, and
Right.
usually within the next 2 to 3 days, about half of patients that have no symptoms but fever will develop symptoms. So,
Okay.
so it's prudent when somebody has a fever right now in our community to say, you know what, you probably should not come. And I know that they've been doing that in different areas, also in other counties.
Mhm.
St. Louis County, for example, and they're reopening as well. And there's temperature checks, and that's important to do. Obviously, we've had not many, but we've had also nurses and physicians that we had to say, okay, no, you have a fever. Let's go and monitor you. And kind of go from there on a day-to-day basis. And some of them develop COVID.
Yeah. And our last question is, during this time, mental health has been a real thing with people having anxiety, and you've never experienced anxiety before. But just with everything that's happening, what do you think will be the best case scenario of keeping our mental health in check?
Wow. That's a really hard question.
Yeah.
And I'll say that, honestly, people that are not healthcare professionals experience anxiety. I will tell you that
Mhm.
healthcare professionals also have anxiety and more questions than answers. And we've also have mental fatigue that sets in because of all these things that we have to take care of. So there's also been reports in Wuhan, China, and in Italy, where there's been a significant um, mental health shift with
Mhm.
a lot of anxiety, a lot of depression, a lot of post-traumatic stress disorder in the months following, the pandemic.
Right.
I predict we're going to have that too here. We're no different than anybody.
Right.
And I predict we're going to have that in both healthcare professionals and people that are not. And I think that's inevitable. I think, we've never gone through this. Most of us have never gone through this type of situation. And I
Oh.
think people have to realize that We will go through that with another virus or another infectious technology in the future as well. I think, people have to realize that, it surrounds us. It's everywhere. We're always at risk for this. And, we have as a community to stand together really and to really make sure that we help each other and we understand that people may have anxiety and try to understand where they're coming from. And I think, people are easy to judge. Well, there's nothing to worry. It's only a virus. Oh, I'm totally freaked out because it's a virus.
Right.
Yeah, and it's okay. I think we just have to discuss about it and we have to educate ourselves about it. And that's what I try to accomplish, through, the training that I have and to try to see what we know scientifically about that, to try to make sure that we say the right things. Unfortunately, it goes really, really fast, right? It's like watching a movie in fast forward. I mean, it's really, really fast. So, it's hard to do all the times. But there will be, I think, significant post-traumatic stress disorder, and we're going to have to be very, very alert to this, and not to say, not again to isolate people that have these problems. I think that's the key. I think we're going to have to be open about it, discuss it. We're going to have to, in the aftermath of all this, have groups that talk about it, just like we have for substance abuse or for other mental health.
Right.
I think that's going to be extremely important to not to forget that and not to say, well, that's not important. It's going to be very important. And that's true for other disease. When patients have heart attacks or strokes, the rate of depression after that, and we're talking months after that, is quite elevated. It's not in the acute phase afterwards, because humans, we tend to, okay, we're going to be positive and all this. It's and when the reality sets in, or when, people reminisce on what happened, especially the families that had significant others that were severely affected or died from COVID. I think we're going to have to remain very alert on helping those people.
I understand that. I totally agree with that. So we have two more questions. One is, can you explain why children are less susceptible to COVID-19?
I wish I could. No. It's and also, some of the children that get infected, they're completely asymptomatic, so no symptoms, or they have this overwhelming, very, very productive immune response that completely shuts down everything. So we do not know. My hunch is your own genetics has to play a role in that. Unfortunately, medicine is not advanced enough that we know our own genetic code personally. So just like, some families we see, they're susceptible to diabetes, hypertension, coronary disease, obesity, mental health. I think we're seeing that COVID and other infections, some individual will respond a certain way and some will. And, oh man, if I would know that answer, it would be great. Obviously, hopefully we'll learn more about this. Yes.
Yeah. I'm quite sure as the months go on, you all will, especially when school opens back up. And
yeah, but it's true. Our own pediatric hospital at SSM had tremendous low number of cases, thankfully, compared to the adult hospital. I wish I would know the answer. Yes.
Yeah. So last question is it true the media is now reporting asymptomatic carriers are not contagious?
Wow. Good questions again. Wow, I'm impressed. All right. So there's been newer studies, in the last week or two that seems to really point out that the patients that do not have symptoms can transmit, but the vast majority of the infections we're seeing is through people that have symptoms.
Mhm.
That's when you have the most virus in your nose and nasal pharynx. This is when you express your most virus, when you cough and all. That's the easiest way for the virus to infect. But yes, since the beginning of COVID, there's been case reports about, hey, the patients have no symptoms. Why
Mhm.
is that? That, there's infection, and there's been all sorts. When we talk, we can expel viruses. When we sing, and this is why, there's so many churches members,
Right.
for example. And the answer is most likely that is the case, that there is some asymptomatic transfer, but it's the exception rather than the rule.
Okay.
So, and I think that's the message, that we should convey, is that unfortunately it can happen. You can't. There's a lot in a lot of infections, including COVID.
Mhm.
There's a time where, I'll take chicken pox, for example. There is a time before you get the rash, 2 days before you were contagious. Hand, foot, mouth disease, and a lot of childhood diseases. It's that principle. With
Yeah.
COVID, it's not as important as a principle.
Yes, most definitely. Um, Thank you so much, Dr. Lacasse. This was great for me and my
Oh,
mental
well,
and my anxiety. So
yeah,
just
great. No,
yeah,
if I can be of any help, that's what I see in one of my roles is to do that, and hopefully, I was able to convey that information so that people understand.
definitely you were. Yeah. Thank you so much.
Absolutely, it was a
Thank
pleasure.
It was. Thank you.
All right,
Um,
thank you.
Everyone, Kelly and I will be back on Friday to discuss all things the Heights. So we will see you Friday. I don't know what time we'll be on, but we'll be back. Thank you so much. Everyone, have a good day.